Children's Eye Care Center at LV Prasad Eye Institute. We also have with us Dr. Pavan Kumar Verkichalla, clinician scientist, who also heads the Myopia Research Lab and Info Myopia Center. They will be joining us to answer your questions. So feel free to start dropping them in the chat box. Meanwhile, while we receive questions from the audience, I would like to start with some key questions to understand the current scenario of myopia in India. So, Dr. Pavan, can you please start by explaining our viewers what is the current status of myopia in India?
Firstly, thank you everybody for joining us today on a Sunday at 3 p.m. The current status of myopia in India is not so great, and that's the reason we thought we will organize this session. Maybe a decade ago, we were looking at much more lower numbers compared to what we have today. Talking about the urban regions of India, we are looking at about 25 to 30% of children aged 5 to 15 years to have myopia. When I say myopia, it's spherical equivalent minus 0.50 diopters or more. If there are parents and teachers joining us, the spectacle power, if it is on the minus side, and if it is especially minus 0.50 and above, we label them as myopia. Now the numbers are on rise, and the predictions also indicate that 1 out of 2 children to have myopia. So this is going to be a new normal for us, especially standing in India right now.
Dr. Pavan, how is the situation in India different from what is being seen in other countries? Are there any distinct trends that we are seeing in India that is not seen elsewhere?
I think in India we are on rise, but in countries, especially in the East Asian region, like Singapore, China, Taiwan, I think the myopia is already at the peak. When I say peak, it's 80 to 90% of the children and teenagers have myopia. So on that front, we are not there yet, but looking at the current scenario of more indoor-centric lifestyle, maybe our numbers may go up drastically.
Mm-hmm. Seems like the more indoor-centric lifestyle that we are having now and more prolonged near work is one of the driving risk factors for myopia, along with genetics playing a role. So, Dr. Ramesh Kekune, I would like to ask your opinion, what plays a bigger role in myopia development? Is it the genetics or the environment? Is one factor dominant over the other?
Yeah, sorry, I'm in Pune. I'm just traveling. So there are two parts to the questions what you asked for this particular thing. There are two types of myopia. One is congenital myopia or early childhood myopia. And the second thing is school myopia. I would say when it happens with the school myopia and also congenital myopia, both have some kind of risk in terms of genetic association, but overall genetic association is not as much as really people think, except in a situation where both the parents are myopic or one of the parent is myopic or the siblings are myopic. They have higher chances having the other sibling or other children having myopia. There, I think there are some genetic association is definitely there. But myopia is multifactorial, genetic and environment both plays an important role.
I would like to ask a follow-up question to that also. Nowadays, we are seeing that children are getting high myopia at a very young age. So what could be the contributing factors to this early onset, and does this poses a long-term risk?
Yeah, the early onset myopia could be because of two reasons. One, more awareness is there among parents. That's why parents bring their child, because when I was in 2000 or 2005, children used to come at 5 years, 6 years, 7 years. Now, even at 1 year, 2 years, more and more parents bring their child for checkup. That could be one of the reasons. And the second reason, which could be having a causal relationship, is having more digitization, more digital time for the patients, having less outdoor activities, this could be playing a very important role also. This was definitely proven during the COVID time because most of the children were inside. They were doing a lot of online work and things like that. That's why that time there was a higher incidence of new onset and early age myopia happened. So I would say both the factors are responsible for seeing more and more myopic children, especially in young children.
Thank you, Dr. KR, for your insightful response. I would request the audience to please drop your questions in the chat box. Meanwhile, we'll move forward with few more questions. Like one point is coming out that time outdoors is protective against myopia and especially the light. We have Swapnil Thakur with us, who is in the myopia research lab, who has extensively worked on light. So Swapnil, I would like to ask you a question whether why time outdoor is necessary? Is it the light level, the wavelength? What is your take on that?
So, Megha, thank you for that question, first of all. So, there are various mechanisms for why time outdoors has been considered to be protective, and we cannot point out the one mechanism. So, the mechanism which includes our reduced accommodative demand, the presence of blue light more in outdoors, the spatial frequency of the environment, and the less cluttered environment in the outdoors. So what is more recently has been investigated is the role of blue light.
Mhm.
So at present, there are several animal experiments and experiments done in humans as well, where the exposure to short-term blue light exposure has been shown to reduce or inhibit the effect of myopogenic stimulus. So that is very positive for us, positive sign for us, but it's very early to comment on whether the blue light has something to do with the refractive development. We have to wait for more randomized clinical trial on that.
Yeah, apart from this, I also would like to add that outdoor and being in high intensity light would also stimulate the dopamine release. And outdoor means you're not doing any close work and you have a uniform dielectric field outside. But then, Swapnil, you had said that blue light is protective against myopia, but commercially we have blue blocking lenses. So, what is your take on it? Should we go with blue? If blue light is protective, then why blue blocking lenses?
Yeah, Megha, so again, a very interesting question. So it's a very common question that should we prescribe blue filter lenses in as a myopia control strategy or not? So we don't have much evidence to indicate that should we prescribe blue filtering lenses or not, we should not prescribe. But there is one recent randomized clinical trial which indicated that even though children were prescribed with blue filter glasses, it doesn't have any effect on myopia progression. So we don't know. We have to wait for more RCTs to comment on this.
Yes, I agree with you. We need to work, but then going with blue blocking lenses, I don't think there is any negative effect. You can still go.
Correct.
And then coming towards the nutrition aspect, Shruti Chamriti from our lab has published a paper to understand what is the nutrition effect on myopia. So Shruti, can you answer my question? Is there a specific food or nutrition that would help us to prevent the onset of myopia or reduce the progression? Is there any risk or relation to?
Thanks, Megha. That's one of the general questions that we hear from the parents. Does eating carrot or eating spinach will stop my child's eye growth? Power from increasing. But at least from the evidence which is already there, it's not one specific food that has any role in it. So as of now, because there's no evidence, I think it's better that we stick with a balanced diet, which has all the micro and macronutrients, which is anyways good for the general health.
Okay. Thank
So,
you.
so to just summarize, this is one of the common questions that we get. What is the diet? What is the recommendation? Clearly, we looked at multiple papers and the evidence is equivocal. We cannot say if you eat this specific food, myopia will be in control. So at this point of time, we do not know what food is really good, but we always recommend balanced diet because there is no specific food that will eliminate or control the progression of myopia. If any, going back to what Swapnil has indicated, in my clinic, I always advocate time outdoors is your food. Sunlight is your food. More time outdoors is good. How much time? well, as much as you can. Something is better than nothing. But from the clinical research standpoint, we say 60 minutes every day will give you beneficial outcomes. When we say outdoor, it has to be really outdoors, not in the balcony, not under the tree, when they're playing outdoors.
Okay, Dr. Pawan, I would like to ask a question like, does physical activity has any role in order to prevent the onset of progression, or how is eye exercises that we are being seen is important in this? Does it has a role? What do you
So right now, when we say time outdoors is good, we say that the time outdoors is good because of various reasons. Number one, the light levels in the outdoor and in the indoor setting are very different. Indoor to outdoor, the light levels are 100 times brighter. Now, spectral compositions, Swapnil was talking about blue wavelength of light or the shorter wavelength, long wavelength, blue light, red light. So the spectral composition in general is also very different. There is blue, red, green, everything in indoor also. But if you are in outdoor environment, the numbers are much more higher. The magnitude of what you see blue is much more higher in the outdoor. And we also say outdoor is good because, yeah, there are good hormones that get released and that will allow the eyeball to stay intact. And maybe to some extent there is debate about vitamin D, there is debate about UV exposure. I'm using the word debate because we clearly do not know if there is a specific entity. So putting all these together, I think overall time outdoors is good and more light is beneficial.
Okay, we will take one. Thank you, Dr. Pawan. We'll take one question from the audience. KDB has a question to Dr. Ramesh Kekuneya. Dr. Ramesh, the question is, for a young patient with progressive myopia and amblyopia, would you suggest patching therapy, or could it be more harm considering that near work is also associated with myopia? Should one be prioritized over the other?
Yeah, can you hear me?
Yes, we can hear.
Okay. So, yes, obviously, the first priority is getting the child see well, whatever optical or contact lens, whatever. Priority is always getting the brain trained to see well. That's my first priority. Having said that, that question has multiple questions within that. If somebody is a myopia, probably the anisometropia is very minimal. The difference between the vision is probably say 20/25 in one eye and 20/20 in the other eye. I would go ahead with whatever treatment required for the myopia treatment. But at the same time, if the amblyopia is because of strabismus and other things, probably you will have to take care of that as we plan this. And sometimes anisometropia can be so much that there could be a significant amount of difference between the two eyes. I would go into mainly in terms of contact lens and things like that. So, answer is very clear. Vision is first. But whether I will continue the myopia treatment progression treatment, it depends upon what kind of, is it antimyopia? Because obviously we are talking about myopia here. That means it's anisomyopia. If it is very minimal, that would not be a hampering, because as you all know, most of the people who are treating myopia, just by giving glasses in a child, the amblyopia gets treated. But if they have a difference or they have different etiology for amblyopia, then I would prioritize amblyopia than anything else. Simple answer is vision first and then progression.
Thank you, Dr. KR. But now, since we are talking about the treatment options for myopia, Saubik Chel, the consultant optometrist from Vijayawada campus, can you please tell us what are the available treatment options that we are available in myopia? What do you prescribe in the clinics?
Yeah. Thank you, Megha, for asking this question. So, as we are mentioning that lifestyle modification itself is a treatment, but apart that, we have optical and pharmacological management as well. In optical management, we have options of bifocal or defocus glasses. in pharmacological management, majorly in India, we have available of low dose concentration of atropine eye drop. Apart that, in contact lens, we have multifocal contact lens and orthokeratology contact lens also available in India.
Thank you, Sobit. So, what do we do when one treatment fails, and what do we do, Nikesh? When one treatment fails, do we put them on another treatment, or how do we go forward with it? What is your take on it? Do you combine the treatments?
Yes, definitely. If one treatment is not working, so probably we need to find out why it is not working, that not giving control, probably compliance, we need to look into it and emphasizing on that. If not working, then definitely we need to add on something like combination of treatment, pharmacological with optical treatment like glasses, myopia control glasses with the drops, or contact lens with the drops, like that.
There are many optical strategies that is available to control myopia. So, Pawan, there are many defocus, like myopia control glasses that are available. So, which one do you prefer to go for? How do you decide on what should we go for now?
So, for the interest of the larger audience, I see that I think few parents are also joining us. So, given that there are multiple options to control myopia, again, I will always refer to what we had 10 years ago. 10 years ago, we were not talking about controlling the progression. 10 years ago, we were not having too many options. Today, we have options in spectacles, in contact lens, in the eye drops formulations as well. Within the spectacles, again, we have multiple options. We have bifocal, where you have two segments, one for the distance, one for the near. Usually, this is given for individuals who are above 40 years, but the same can be given for the children as well for controlling the myopia. Then we have something called defocus spectacles or peripheral defocus spectacles. Within that, we have multiple companies that are there. Again, the philosophy is the periphery in the eye. There are two regions: the center region and the peripheral region. These spectacles target the peripheral region of the eye, and this is known to control the eyeball from growing. Keep in mind, I'm using the word eyeball from growing. Myopia, the concern for us is eyeball is increasing in size like a balloon, and we don't want that increase. Whatever myopia control treatment that we are talking about is to control the eyeball from growing. Basically, we want to stop the balloon from increasing in its size. Now, within the spectacle, there are multiple, within contact lens, multiple. At LV Prasad Eye Institute, we follow a impact myopia guidelines that were developed involving ophthalmologists and the optometrists. And based on that, we see what is risk factor in that individual, and we put them on specific treatment strategy. So it's much more personalized. I think I also recommend all the practitioners also joining us to be following a personalized myopia care, given that each child seems to be very different and they behave differently when we prescribe a treatment as well. So I cannot hunch towards one specific treatment, but holistic approach, personalized care.
Moreover, it is a tailor-made for everyone, right. Customized. Right. So now there is a lot of what talks about orthokeratology, which is a specialty contact lens and is helping in control myopia. So I would request Sujit Shah, our consultant optometrist, to shed some light on orthokeratology and multifocal contact lens.
Thank you so much, Megha. I think the first thing what I always observe in the clinic is that we are giving treatment options, but what are we thinking in terms of patient and the parents' perspective also? We should first think about that, okay, what is the child need, what the child does, what is the hobby of child. We go with a different treatment option, but we do give them multiple options. These are the options available, and these are the things it will help your child to control and to see clearly. Yeah. The glasses, what Dr. Pawan indicated, these are the special type of myopia control glasses. Mm-hmm. Even the contact lenses work in the same mechanism, but this is something that there will be a glass free for a whole day. If the child doesn't want to wear the glasses, they broke the glasses often. But there are some kind of limitation. There is some kind of limitation power. So different company have different types of limitation, and based on that, we do give. As we indicated, like someone who's having the orthokeratology lenses are the very hard lenses that you will wear in the lifetime, and you will sleep with the lenses. And when you wake up in the morning, in the whole day, you will be glass free. Now, some of the child doesn't want to wear the lenses, but there is something called multifocal contact lenses. These are the soft, special type of multifocal lenses that will control and slow down the progression also.
Okay, maybe I'll ask you one more question, which is from Sayanti. Sayanti, thank you for asking that question. The question to you is, how effective are myopia control glasses or multifocal contact lens compared to other treatment? Which one do you think is better in children of 10 years, and how often should we monitor?
The answer for this will be that, see, every myopia control glasses, the content has some kind of percent efficacy, and the range is between 50 to 70%. Based on the need and the demand, whatever we have, we do give treatment. But yeah, obviously there are different myopia control glasses, contact lenses, but they ranges between 50 to 70%.
So there is no one treatment dominant over the other.
See, we do personalized myopia treatment and we have their own opinion, but obviously we'll go with first one therapy. We'll see how this is happening, and based on that, we add the combination therapy.
Okay. So, do we have any other questions from the audience?
Yeah, there are a lot of questions. Maybe we should go one by one. Do you want me to raise? Okay. This is from
Rishikesh.
Yeah. My daughter is 1.3 year old and a cylindrical power of 3.5. How is this going to affect her in the future? And how progressive it could be in the future? Is it good to be treating often? Threatening for her. I think children usually will have a bit of plus power when they are born. And as they age, they tend to get nullified, or it gets to zero. And if there is triggering factor, it goes towards the minus side. So everybody is born with a bit of plus power. We say hyperopia. And now you're saying that there is cylindrical power, 3.5, little on a higher side, but 1.5, it is always difficult for us to do a refraction or to get the appropriate power. Threatening, I mean, 3.5, just a mere cylinder will not be sight threatening, but we need to really monitor as she grows. Now, what's also important is what's the family history? Are the parents having minus power, cylindrical power? Usually when the kid rubs a lot, also the front portion of the eye called cornea, that sort of leads to the power that you're indicating of astigmatism, cylindrical power or the astigmatism. Dr. Ramesh Kekunaya sees a lot of these children, and it will be good, Dr. KR, if you want to add a couple of points on that.
Yeah, I just missed that. The age of the child is 1.3.
1.3. Yeah.
1.3. Okay, we are looking at a situation. The child is having myopic astigmatism. In my opinion, 3.5 is a little bit large for that age. One thing is that what we have seen over a period of time, that 3.5 will not progress. It's a little bit high for that child. We don't have to rush and give that because the child's need is not so much at 1.3 years. But eventually, I'm expecting that glasses has to be given for this child. In terms of progression of minus 3.5, in the last 15 or 20 years, what we have seen, they don't progress. Having said that, they may be a risk factor for myopia development. You know, at this point of time, she is 3.5. After 6 months or 8 months, she may become minus 0.5 with 3.5 and then minus 1. We really have to treat this kid as a pre-myopia. That's what my suggestion is. And the child would require some kind of glasses. I am not worried here that child will progress in terms of astigmatism. The child may develop myopia as any other child. So if the precautions are taken care in terms of, reduced screen time, increased outdoor activities, and probably need to wear glasses. Otherwise, I don't see any life-threatening, sight-threatening disease like keratoconus in this kind of situation.
Yep.
Thank you, Dr. KR. There is a question from Syed coming up that is reading in dim light cause myopia. Swapnil Thakur, can you please take on this?
So, Syed, we don't have the direct answer for this question right now that reading in dim light can cause myopia. But of course, we have some clarity on if someone reads on a dim light or use smartphone in under dim light condition, it will have some negative influence on their circadian rhythm. which means that their sleep pattern will be disrupted, and that could have an indirect impact on the overall ocular growth. Other than the influence on the circadian rhythm, using smartphone under dim light condition could, of course, have some level of eye strain. Sudip, do you want to add on?
I think reading, rather than we have to see that what the child is doing, how long they are using, and what are they using. Because now, as we are in the digital India, we are much on the near work, and we use tab, iPad. But for how long they are using, at what distance they are using, that is very important.
So I just wanted to add one line that why this question is very important, because when we see the wavelengths of the light coming out from the smartphone, there is a blue dominant wavelength, and if you read on a smartphone, the blue wavelength will suppress the melatonin level, which is also a sleep hormone. So basically, don't use a smartphone under dim light conditions.
Thank you, Swapnil. So there is a question from Preetu Sinha. If someone is having -1 diopter sphere, can they wear contact lens? Sujit Shah, would you be able to take this question?
Yeah. We can. They can wear contact lenses. There, as I indicated, that what is the patient age is. If they are younger, yeah, we can use that. But there are some kind of things what we have to keep in mind, that what type of contact lens are they looking for and what is the need. Because with the contact lenses, the normal contact lenses, we can't see with the lenses. There should be no any kind of water touch, because we don't know what is in the water. But yeah, they can wear the contact lenses.
Okay, how much screen time is safe? I mean, the lower the better. There is no safer time limit to say that. I think the WHO gives a criteria of if you're less than 2 years, 0 minutes of screen time. But these days, saying that the child has to be away from the screens has become a challenge, given that all these schools, like you have rightly mentioned, Kinibu, that they have as a part of curriculum, they have to see a screen to do the homework or whatever. So what we advocate is maintain distance, keep it far away, and if you can connect your laptop to TV, bigger screens are always better compared to holding something closer to the face, and limit the screen time. We cannot say that, okay, be away from it, but I think you might want to give the phones in the hands of child much more sensibly for various reasons. We talk only about myopia, but I think there are other health concerns that the child may have using the smartphone for a prolonged duration of time.
Yeah, given the more academic demand to work on near work and tabs nowadays, Pawan, can you please add on one more thing, like how can schools and government take action in order to help us prevent myopia?
I think this is important. When we talk about the stakeholders include the clinicians, the parents, teachers, because that's where the children are spend most of their time in the school. Now, as a government initiative in countries like Singapore and Taiwan, they have something called 1 hour mandatory recess time. So children go to school, but as a part of the curriculum, 1 hour is spent in outdoor environment. Outdoor is good for multiple reasons. So I think if the policy change has to be brought in India as well, we really want to see that all schools will have that 1 hour of mandatory outdoor activity every day.
We have one more question that for Sujit, like how reliable is the Ocumentra app?
I think the Optical app is like app which will predict that how the childhood progression will happen. If you ask my opinion, obviously they are okay, but I don't completely own that app. But yeah, we do take detailed myopia history. Based on the risk factor, we go with the treatment option. But yeah, there are also one of the things what eye care practitioner normally do.
Kiar, I would like to ask you the next question. This question is from Ayush. Can long-term use of myotro eye drops cause damage to eyeball? And what potential effects or complication might arise from prolonged use?
Most of the times, these drops, low concentration atropine is quite safe. When I say most of the times, more than 95% of the times it is safe to use, because earlier we used to do a higher concentration of atropine, that is close to 1%. The pupil used to be dilated all the time. When somebody's pupils are dilated, that can affect your focusing capacity, that can affect your reading capacity, that can also impact while going out, more sunlight can go into your eyes. There were problems with the higher concentration. So low concentration, using it for a long term will not be a problem. Having said that, there are evidences in very, very rare children. It can cause some kind of redness. It can cause some kind of focusing problems. It can cause some kind of intolerance to light. And very, very rarely, it can cause some crossed eye in children. So, looking at the benefit and risk ratio, risk is very, very minimal. That's why people have invented this and studied extensively using this low concentration. This is not a high concentration atropine. So people get scared. Most of the patients and the parents, they ask me, using it for a year or 2 or 3 years, will it cause any ocular side effects? In simple words, it's pretty safe to use.
Okay. Thank you, Dr. KR. We have a question for Saubik Chel. Which one is better, Saubik, Ortho-K or defocus spectacles in terms of slowing down the progression of myopia?
Hi, Spandan. I think Ortho-K or defocus spectacle, I mean, both are working well in terms of controlling the progression. So depending on case, I think we should choose that. But as per my observation, both are actually, I mean, effective well. Few studies are indicating maybe Ortho-K is working bit better than defocus glass, but I think both are working well. I can ask the same question to our other clinician too, what they observe in their clinic.
Kausalya, would you like to add on to this?
I think she is not host, so she can't unmute.
Okay, so I think orthokeratology is a nighttime wear lens. The children has to wear in the night, and during the day they don't have to wear, which means they're spectacle free during the entire day. The parents will have total control. Then the multifocal contact lens or other type of contact lens are daytime wear contact lens. So these are contact lens modalities. Spectacles are, you're wearing it during the daytime. Now, in terms of efficacy, both show similar outcome. I thought I would just emphasize on the need for nighttime wear. If somebody is a sports person, or if they want to be spectacle free while playing football or cricket, orthokeratology is one of the good options that parents can consider.
We have another question from Tripur now. Which one is best for a about 10 years kid, myopia control glasses or multifocal contact lens? Nikesh, can you please add on to this?
Yeah, definitely. Generally, for 10 years kid, we don't directly go blindly with any glasses or contact lens. Definitely, we follow a impact guideline which says IMPACT different, whether it is true axial myopia, then mapping the risk factor, depending on the risk factor, whether it is progressive in nature or not, then what will be the appropriate treatment according to risk factor, we can go with that. And it's depend on what are the factors, like children's dependent, what they need, then we can decide on glasses is better option or contact lens, like that. It's not one treatment suits for all, probably personalized care needs to be.
Yeah, again, it's boiling down to customized treatments for everyone. That's what we follow here also. And the next question.
I think there are some surgery related questions.
Yeah.
One is, can somebody develop myopia after surgery? Or maybe Dr. KR, you might want to educate people on what's the suitability for somebody if they want to go for refractive surgery to start with, and maybe related any complications.
Yeah, the question is what is the eligibility to get the refractive surgery, right? So,
Yeah.
Number one, they should be having a non-progressive myopia. That means your spectacle power should not keep on increasing. Ideal age is somewhere after 20 years of age, we consider any candidate for at least to consider surgery. But even if at 20, every 6 months your glasses power is changing by 0.5 or something like that, then you might have to really reconsider and probably wait a little bit longer before you consider. Obviously, when you consider, there are other thickness and other part of parameters we need to check, like corneal thickness, lot of technical things we need to do, whether a person is fit for one type of laser vision correction or some other type. So that will be checked by an ophthalmologist, and then will be advised accordingly. So number one, you have to wait till the age is 20 years. Number two, the myopia should not be progressive. It should be stable at least for 6 to 8 months before you consider. Second question is, any kind of surgery can cause myopia? Very, very rarely. It can cause some kind of, eye surgeries can cause some cylindrical power or astigmatism power, but not myopia.
Thank you, Dr. KR. We have a question from Neena Saju. Is myopia ever reversible, and is there any exercises or activity to prevent myopia? Shruti, can you please add insights to this?
So normally, technically, the myopia is not reversible. What we should understand is myopia occurs because usually the eyeball grows in size. The more your eyeball size is, the more is your myopia. So it's similar to like your height. Once you grow tall, it's not possible that you grow again short. So similarly, the eyeball is also like that. Once it grows long, it doesn't come back to its normal less thing. So yeah, myopia is not reversible, at least when it's usually because of the increase in the eyeball size. That's the answer to it. Unless, yeah, of course, there are surgical options as discussed by Dr. KR on how to correct, but unless you go for them, usually it's not reversible.
Yeah, Motishi, can you add on this by giving us insights of how exercise or activity can prevent myopia progression?
Thank you, Megha, for the question. So there are multiple studies done on various kind of exercise, like typically the netra yogas or the eye exercise and also the physical exercise. But to get into a conclusion that this exercise will be controlling myopia, we are still not at that point to answer. But doing physical activity outdoors, as we are seeing from the morning, like stressing on it. So outdoor activities along with physical exercise in the sunlight will be helpful for myopia.
Okay, thank you, Motishi. Pawan, can you add on how often should their children's eyes get tested, or how often should they come for follow-up?
So if the child is young, we would like to see them in every 4 to 6 monthly, especially if we put them on some sort of myopia control treatment. So we now have good technology in hand that can help us what's the status of the treatment, or even if somebody is not on treatment, we want to see what are the changes within the eyeball before we start the treatment. And the biometer especially help us to understand if the changes are rapidly happening or not. So my call is always 4 to 6 monthly at the start. Once it stabilizes, then we can push it back to 8 months or maybe 12 months. At the start, younger than, I would say, 15 years, if the myopia is still progressing, please consult either optometrist or ophthalmologist every 4 to 6 months to monitor your progression.
Okay, you can take the next question as well.
Megha, we have some question in our YouTube chat box too. Like one participant is asking, is there any relationship between myopia and amblyopia?
Yeah, Dr. KR, you want to?
Yeah. There is a relationship. Higher the power in one eye or higher the power to begin with in both eyes, if they are not treated on time, amblyopia is nothing but lazy eye. If the power or spectacle power is not corrected early enough, they can develop amblyopia. So, does all the patient of myopia develop amblyopia? No. If they have to begin with, if they have moderate to very high myopia, If they're not worn glasses, they can develop amblyopia. But most of the myopia patients, the school-aged, very small myopias, they don't go into amblyopia very much. There is a relationship, but it's not very common to have amblyopia in myopia. Not very common.
Irene Sophia is joined from Middle East. She has a question on atropine. Irene, firstly, thank you for joining. The question is, if somebody is on treatment for 4 years, what's the schedule? When do you really stop the treatment? I will add first, again, we follow a guideline called Impact Myopia Guideline. We look at late teenage as a stop point. Late teenage provided 2 back-to-back years if there is no change in the treatment. If the child is young, and although if it is stable, you might want to be extra cautious before you take them off from the treatment. So ensure that the eyeball is really stable, which means you're looking at 15 plus years, or maybe 2 back-to-back years at a late teenage where there is no change. Dr. Kiar, you want to add anything on atropine on that front as well?
Nothing as such, Pawan. Late teenage is where we can start a stabilization before we really stop. So late teenage is how much? Probably 14 or 15 years. Or in some of the patients, because 10 to 14, I would still hold off anything, because that time either because of puberty or something, some changes happens, we will wait till then. Obviously, it's a long haul when we start atropine. This is something we need to have a discussion with the parents.
Irene, since you are joining from other country, can you tell us what's the status of myopia there? You can unmute and speak.
Yes, hi, Pawan.
Hi.
So I'm joining you from UAE, so that's where I practice. The status of myopia here is not there. We do not have any large-scale prevalence study or anything as of now. Still, people are already started working on it. But as a clinician, what I'm seeing practically, definitely I'm seeing the rise, especially after the 2020-2021 stage. Increase in existing myopia and a lot of more incidents of new cases. That's what I see here practically.
Yeah, only thing in Middle East becomes difficult is outdoor activities. I don't know how do you
Absolutely.
manage that.
We are just starting off getting into the heat phase. So for the next 6 months, we are tied down indoors. So people either travel or they don't come out. Even yesterday, we had this discussion with one of the parents where, I was trying to tell them outdoor. I told them, okay, don't put them directly under the sun, but at least in a space where there's a large window, where there's more light coming in and open space. That's the status here.
I see that there's a question by somebody whose name is Myopia. So thank you for asking the question. So the question is, apart from low-dose atropine, do we have any other pharmacological drops? We had something called 7-methylxanthine, 7-MX. I think this is going to be the future. It's a tablet formulation, not in the Indian market yet, but that's one of the options that we had. Scopolamine, parental, and other pharmaceutical agents that we had as a part of research, at least, not so much in the clinical practice, but largely atropine is widely used globally for myopia control.
Yeah, we have a question from Syed and Kausalya. Can you please state that when will we consider that a patient is progressive myopia?
Yes. Thanks for the question. So the progressive myopia term itself indicates when the minus power is increasing in the number. So if a child has a power increase of 1 diopter for every 1 year, so it considered as a progressive myopia. That progression can happen in the 6 months or early also. So to manage that, we have multiple options for myopia.
Okay, thank you, Kausalya. I have a question to Pawan. Like now, many job opportunities would demand good eyesight and good visual acuity. So, are there any barriers for myope in order to join the defense forces or any other job opportunities as such?
From the Indian standpoint, if you look at the website, it indicates that there is cutoff for the myopia, there is cutoff for the axial length, also axial length meaning the eyeball length. Beyond 25.5, 26.5, if you want to be on the war field or a specific criteria within the armed forces, I think you may not be eligible. Even a few schools in India that are army public schools or maybe few others defense related also, I think, have that cutoffs in place. So yes, myopia, when we talk about as a spectacle power, is it really a condition, or we also at times label this as a disease? Because myopia sort of leads to some complications which may lead to visual impairment. Not in everybody, obviously, but very small percentage. Keeping that risk in view, I think the defense and the armed forces have this specific criteria.
Savi, can you please take a question from Pragati where she's asking what should be the safe near reading distance while the child is of age 12 and is using digital device or reading material?
Yeah, ideally we used to say one hand distance. One hand distance, ideally we can say as a safe distance for reading anything from digital device or maybe from book or any reading material. But one thing is important, what you have to add with this is that please tell that not to read for long time at a time. Please take break after 20-30 minutes of reading or maybe watching something in screen.
Okay. Thank you, Saubek. We have another question from Said again. Bhavani, can you please take up this question of what is the global prevalence of myopia?
So, there are few studies where they indicate that by 2050, the 50% of the children population can become myopic. So, which is considered a burden globally, right? So,
yeah, I think by the year 2050, it is projected that 50% of the world population is going to be myopic. But then the good news is that we have treatment options and there is an opportunity for us to prevent the onset of myopia as well as treat them.
There's a lot of questions. Saubik, if you don't mind, see the questions in the YouTube as well.
Yeah. So there is a question that a 11-year-old boy, they visited somewhere and they gave atropine eye drop along with spectacle. And the concerned guardian is asking that is there any other way or best way to treat this childhood myopia? What outcome of this treatment they will get, and when they can withdraw this all treatment option?
So, Nikesh, can you please take this question?
So maybe I'm repeating.
Yeah.
11-year-old boy. In other hospital, they started atropine eye drop along with spectacle. The question is, what is the best option to treat this childhood myopia in this case? And what, could be the outcome of the treatment, they will get? And when they can withdraw this all treatment?
Yeah, similar kind of question which I have already answered about 10-year thing. Like we don't shoot in dark. Specifically, we want to look at the risk factors, what are the risk factors, and then we want to decide on what could be the triggering factor to progress, and then we will decide on different options. We have multiple options, definitely. Yeah.
So that means what Nikesh is trying to tell is that we have to thoroughly check the history first, then we have to do few tests, then only we can come into conclusion that what kind of treatment we should give in this particular case.
Looking at the multiple questions as well. One more is on
Repeated.
yeah. What is the current status of repeated low-level red light therapy for myopia control? I think there are multiple clinical trials conducted indicating the efficacy of the RLRL, in short, red light therapy for myopia control, largely coming from East Asian countries. There is little concern about the safety. This is not in the Indian market yet. Again, we need to wait for long-term effect. before we sort of give it in the clinics. Again, in countries like New Zealand, in countries like Japan, in countries like China, I think this is already in the market. So we do not have first-hand experience, but from the research context, this shows good efficacy in controlling the progression of myopia.
So there is another question in YouTube that how much time we should spend outdoor if we have keratoconus. So Dr. Care, would you like to add something in this?
Yeah, keratoconus is a different aspect altogether. See, the minus power and the myopia can be because of the length of the eyeball, increased length of the eyeball. It can be because of the lens is not in a correct position. It also can be because of protrusion cornea, and the lens effect. So I wouldn't say there is any relationship, provided there is no axial component to that keratoconus. Then it can impact.
Thank you, Dr. Care. So Dr. Pavan, Sangjukta is asking from research point of view regarding outdoor time quantification, what can be the clinical implication of those, as children or subject are generally reluctant to wear those light meter devices?
Reluctant to wear
Light meter devices.
Okay, can you repeat that for me, please? Sorry, I'm parallelly looking at the Zoom questions.
Correct. So from a research point of view regarding outdoor time quantification, what can be the clinical implication of those light meter devices, as students are not?
Yeah, so there are a lot of wearable light trackers that are available to monitor the time the child spends in outdoor, the amount of light the child is receiving. Much like your any of the wearable watches that you have, smart watches which calibrate the number of steps to the calories. Same way we look at the light and then convert it to the time in outdoors. Now, in few countries, again, there is a practice of giving this as a treatment strategy to get more quantifiable outcomes. There are people who are researching from India's standpoint. We also developed a light tracker that people can wear like a badge, and we understand the time outdoor, how much time it's good or bad. I think any quantifiable quantifying agent or anything that can change the behavior is good. Saying that, I want to highlight to all the optometrists and ophthalmologists or any other person who has joined here, there is so much to be done in the field of myopia. And if you're an engineer as well, I think there is scope for you to contribute, especially for designing cost-effective strategies, cost-effective trackers, or anything cost-effective so that we can prevent or control the progression of myopia.
Okay, there is a question like, what is the power range for orthokeratology lens? Is minus 9.5 diopter power available? So just what you cover.
I think there are different companies coming up with the power ranges, but normally up to -6, and there are some soft orthogonal lenses they can go up to -10, -11. But yeah, it can go to -10.5. We can customize the orthogonal lenses also.
I think there is one more question. What possible options are available to avoid high power glasses? And will this affect studying in the future? Sorry, I'm just.
They both are myopic, so they want to make sure that the kid doesn't get.
Yeah, go on, please, go on.
Okay, so to add on to that, Rishikesh, so because you both are having myopia, it's better you get regular follow-ups, as they are having cylindrical power right now. But 6 monthly once follow-up is better, and following the lifestyle modifications would help in controlling their power progression.
Any more questions in the YouTube, Shobik, that you think we should answer?
Yeah, so there is a question that my girl is wearing -13.5 spectacle in her eye, and her age is around 15 to 16 years. So can you please tell me what is the future risk for my girl?
15 to 16 years, and what's the age?
Age is 15 to 16, and the spectacle power is 13.5.
Right. Again, this is not a teleconsultation. We want to just make it clear. 13 years is already on a higher side. 13 to 15 years is still not attained stability yet. Yeah. So you might want to consult a practitioner, and it's better that there is some treatment is given to control the progression of myopia.
Given the high myopia, you should check the retina also yearly once.
Absolutely. Any myopic individual, ensure the retina is checked. The whole worrisome problem, the worry for us is because of the eyeball stretching, more complications. Unless the retina is seen, you will not know if the retina is healthy or not. These days, we have very nice equipment, portable fundus cameras as well. Even without dilatation, you will be able to see the central zone of the retina at least.
There is an interesting question that tomorrow, if I mean, get a child, and from now on, what could be the precaution I should take to prevent myopia?
It's really future planning. Genetics, I think if the problem comes with the consanguinity. The problem comes when there is already some syndrome within the family, but otherwise, just because one parent is myope or both the parents are myope does not mean always that the child will have myopia. Dr. KR, anything to do with genetics that you want to highlight?
No, I don't think so. When the child is already expected to be born, unless there is some kind of prenatal scanning which detects some of this myopia or myopia associated thing, I would not do anything at this point of time, and just have an early checkup for the child, especially if both the parents are myopia. I wouldn't bother too many things at this point of time.
A user fast and curious, the name of user, fast and curious, want to know that could we use eye drop to overcome eyesight in early ages for children?
Prophylactic eye drops probably may not be a good idea, but just natural things like from day one of the baby is born. There is a saying that first 1,000 days after the baby is born, don't give them any digital media other than family call and things like that, and then outdoor games. All these things can be taken care, and obviously early eye checkup is what I would do. Other than that, I don't think so there is anything else.
So Sujit, there is one question.
Sorry, just 1 minute. So there is something called pre-myopia. The child is not myope yet, but if there is an extra risk, I think we say that we only consult and then monitor regularly. I thought I'd bring in that word pre-myopia. Go on, Shobik.
Yeah, so there is a question that 9.5 is the refractive error. Is orthokeratology lens is available for that RX?
I think that was previously answered. It is available for minus 9.5.
You can customize the lenses also.
So power is one factor. Maybe we have to do few other tests also before to give you the orthokeratology lens. So visit the nearest practitioner. So another question is the patient has high myopia and her visual acuity is 2500. History of ROP, PHPV, macular scar and eccentric fixation is there. Squint surgery will recover in right eye and left eye vision is 2050 and age is 23. I don't know what is the question here. So they just give entire history. They missed the question there.
Yeah.
So,
looks like whether the squints will recover both the myopia. If that is the question, it won't. And the mechanism of myopia in all of this PFE, ROP is different because the retinal health per se is not good. So we are looking at a different kind of myopia here. And whether the squint surgery, if I have understood correctly, that will cure the myopia? Probably not. Whether the squint surgery can help, probably help the patient. Obviously, this is not the forum to discuss. Probably need a consultation in detail. We need to see into it.
Just want to highlight that today you are seeing on the screen our mix of ophthalmologists, optometrists, researchers, and we also have myopia fellows. So I want to ask one question to Parikshit, who is a myopia fellow looking at parental awareness on myopia and the myopia control. Any insights on that, Parikshit, as of now? I know it's interim analysis, but if you can educate.
So as of now, there are almost 160 participants filled up that questionnaire. So the study was parental awareness about myopia in Indian populations. So there are in the questionnaire-based study, there is almost 27 questions are there, and in that questionnaire there are almost three main domains. One is parental knowledge, parental concern, and the educational resource. So from parental knowledge, there are some of the questions like it shows some majority of the parents shows positivity that they are aware of the myopia will complicate, like those having myopia complications having vision related, and second was on myopia progression control. But in spite of that, some more majority of the parents were known like myopia can be controlled, but few of them didn't aware of that myopia progression can be controlled. Next is concerns, like 50% of the majority of the parents were concerned like we have to do the early checkups while having myopia. So, but almost 23% from above that range didn't aware of that. So, in that space, we should have to increase the more awareness, including the parents. So that's where they are more aware regarding the child's myopia.
So more awareness is definitely needed, and also a couple of points before we close. There is a lot of bullying that happens in the school. So watch out for that as a parent. I think as a practitioner, as a parent, I think we should stop that. This is a serious issue. The child may not express, but watch out for these and ensure this does not happen. The burdens that we talk about, in relation to myopia is not because only the pair of spectacles or contact lens. The burden goes beyond that. It's because of the stress that the parents or the child may undergo. It's because of the complications that the child may have. I think the job opportunities as well, like we spoke about the defense, army, etc. I think there are both direct and the indirect costs, and it's time for us to combat myopia. Whoever has joined, I think this is great. Everybody has opportunity to work on this problem. We work a lot on myopia prevention, myopia control, and looking at what is the one factor that we can say, hey, tomorrow you are at risk. Right now, the ground is very open. Everybody can contribute, and I think every bit counts today. Over to you, Nila.
That brings us to the end of the session. And on behalf of Team Myopia, I would like to thank Dr. KR for taking up the question and providing us with his valuable insight, and also the audience who asked those wonderful questions. So as we observe this Myopia Awareness Week, let us aim to advocate for early diagnosis and also evidence-based practice, public awareness, and together we can manage and prevent myopia. So thank you once again for joining, and we look forward for more discussions in the future. Thank you.
Thank you so much, everyone. We'll drop an email if there is any question. We'll drop an email. You can write to us.
Yes.
myopiaresearch@lvpi.org.
Thank you.
Thank you so much, everyone. Thank you.